Good evening and welcome everyone. Jalasi. Bienvenue tout le monde. Falcha. My name is Dr. Richard Eisner, Associate Vice President of Research, Graduate and Professional Studies, and Interim Director of the Brian Mulroney Institute of Government. I'd like to welcome all our guests joining us this evening online for the Brian Mulroney Institute of Government Distinguished Speaker Series, and I'd love to thank all of you for coming out, such a great turnout this evening. The Minister is a popular draw. So I'd like to begin this evening's program with a territorial land acknowledgement. St. Francis Xavier University stands on the lands of Mi'kma'ki, the ancestral and unceded home of the Mi'kmaq. We express our deep gratitude and appreciation to the generations of Mi'kmaq who, since time immemorial, have loved and stewarded these lands and the beings that call them home. Colonization is not just history, it exists in the present tense. And while we strive to decolonize ourselves and our university, we know there is still much for us to learn. We are committed to doing the hard work of self-reflection and to repairing relationships with the Mi'kmaq on whose lands we reside, including embracing the Truth and Reconciliation's calls to action and embodying their spirit in our day-to-day lives. We are all treaty people. This evening, the Brian Mulroney Institute of Government is honored to welcome the Honourable Michelle Thompson, Minister of Health for the province of Nova Scotia, as part of its Distinguished Speakers Series. A female leader and community volunteer, the Honourable Michelle Thompson was first elected to the Nova Scotia House of Assembly as MLA for Antigonish in 2021. A proud Cape Bretoner who now calls Antigonish home, Minister Thompson has resided in the community of Cloverville with her husband Darren for over 25 years. As a mother of three, Minister Thompson extensively engaged with community through her previous involvement as a board member of the Antigonish Celtic Soccer Club, the Fast Swim Team, L'Arche, and Arts Health Antigonish. Having held various prominent positions in the healthcare sector, Minister Thompson possesses a deep understanding of the challenges and opportunities within the provincial health system. Michelle has been a registered nurse for 30 years, working both in the front lines as a care provider and in leadership roles. Prior to becoming MLA, Minister Thompson held the role of CEO at the R.K. MacDonald Nursing Home in Antigonish and was president of the Continuing Care Association of Nova Scotia. Taught nursing part-time at St. FX University and has served as a part-time therapist for a not-for-profit organization. Tonight, Minister Thompson will speak about Action for Health, a strategic plan for transforming healthcare in Nova Scotia. And following Minister Thompson's presentation, I will invite Dr. Katie Obrecht to moderate a bistro-style Q&A discussion up at the front. So we're going to order in the cappuccinos and let the Q&As go. So Dr. Katie Obrecht, I'd like to introduce, is Canada Research Chair in Health Equity and Social Justice and Assistant Professor in the Department of Sociology, and a fellow at the Brian Mulroney Institute of Government at St. FX. Dr. Obrecht has a PhD in Sociology of Education from the University of Toronto and is an alumnus of the inaugural cohort of the Canadian Institutes of Health Research Institute of Health Services and Policy Research Health System Impact Fellows. That's a long title. As the director of the Spatializing Care Intersectional Disability Studies Lab here at St. FX, Dr. Obrecht leads an interdisciplinary research program that maps health services, social policies, and community resources related to marginality, mental health, and resilience across the lifespan, with a focus on rural communities in Atlantic Canada. Dr. Obrecht's teaching and research in sociology draws on health policy studies, intersectional disability studies, gerontology, and participatory decolonizing and arts-informed qualitative research methods to analyze disability, aging, and mental health education. Dr. Obrecht is an associate scientist with the Maritime Strategy for Patient-Oriented Research, SPORE Support Unit, and is a board member with Mental Health Research Canada. She has served as president and executive board member with the Canadian Disability Studies Association and as a board director with Eviance, the Canadian Centre on Disability Studies. So welcome, Minister Thompson. We look forward to your talk. And after your presentation, Dr. Obrecht, welcome for the Q&A. Over to you.
Thanks, everyone. Before we start, I think there's some folks who's at PGov 101. Yeah, and just to make sure that you sign in, I really appreciate that you came out tonight, but I would hate for you not to get the credit for filling the seats. Yeah, so I just deeply appreciate everybody coming. So I'll just leave this here, not to call you out, but feel welcome to sign that. So thank you, everyone. As I said, my name is Michelle Thompson. I'm a registered nurse. Are there any other healthcare workers in the, here we go, always, yeah, welcome. Anyone in nursing or dietitian, dietetics, kinetics, okay, welcome. That's great, it's good to see everybody. Any Cape Bretoners? There we go. Yeah, that's good. Occasionally I'm in a room where there's no other Cape Bretoners and I'm incredulous that it actually happened. So I was in one the other night and I felt a bit adrift that there were no Cape Bretoners. So I'm originally from Middle River, just outside of Bedeck, and came up to nursing school in 1990 to train, as we called it then, at St. Martha's School of Nursing. I'm a third generation nurse. My mom is a nurse and my Aunt Wendy is a nurse. And we had two beautiful aunts, my grand aunt, their Aunt Helen and Aunt Doris, who are nurses as well. And so here we are, I am as a third generation nurse. Just very proud to be in the profession that I'm in. It's absolutely been the gift of a lifetime to be able to work in healthcare and care for people and accompany people, and been very lucky. I did graduate from St. X when my kids were really small. I thought it'd be a good idea to do my nursing degree by distance. And so you can ask my husband about those years. They were tough. And so I did graduate in 2006 from St. X with my degree in nursing, and learned a lot as well. So anyway, very, very grateful to be here today. Most of my career has been spent in Antigonish. I started out working, well, there was no work, and we'll talk about that a little bit. If you can imagine, there was absolutely no work for registered nurses when I graduated in 1992, none. I worked quite happily for a period of time as a PCW, and I worked in a variety of different places, and had to leave for a little bit of time, went to Scotland, and when I came back, things had started to change. But if you can imagine 30 years ago, no work at all for nurses. So we'll talk a bit about that. So it's my privilege to be here tonight. As I said, I'm a proud Cape Bretoner. Elected in 2021, and we can talk a little bit about that. I know there's some people who know me very well in the room, so I'm acutely aware of that as well. And, sometimes you have to be really humble when people know you well. So I appreciate all of you that know me well for coming tonight, because you've heard me talk a lot over the years. So I have a slideshow. It's really for me. It's to prompt me and to remind me what I want to tell you. So I just want to talk a little bit about where we were. And Action for Health, I'm just going to contextualize it a little bit for us. And I'm going to talk about 1990 when I graduated, actually. So we had too many doctors and too many nurses, if you can imagine. And so we had to, the governments at the time decided that we needed to do something a little bit different. And so I was, as I said, a diploma nurse. And in 1995, Nova Scotia phased out the 2-year diploma program, and we went entirely to a 4-year baccalaureate degree. And because there was no work, there was too many nurses. And in fact, out of my graduating class of about 30, I believe only one of my classmates actually works at St. Martha's Regional Hospital. I've had classmates on either side, ahead of me, but I think only one actually works there. And so they changed the education, and I know that there are some physicians in the room, and I believe around the same time in the early 90s, the training for physicians changed as well. And there was just a sense that we had to do something different because we had so many folks. I would also say at that time, there was a lot of infrastructure investments. So St. Martha's, I think, was opened in 89, 90. And so that was a new hospital. I think you'll still hear some of the staff refer to the old hospital, which was torn down, as the old hospital, and the new hospital. Here we are 30 years later, but it's just some of the vernacular that we use. And I know that certainly in my home community of Bedeck, we had a new hospital around the same time. So there was infrastructure investment. But I would also tell you that is around the time that we started to see a bit of constraint around healthcare systems and trying to figure out how we were going to cost contain. And I remember that so well because the hospital had opened. It was this new, beautiful spot, and there was this program called GRASP. And so everybody, yeah, so there's a couple of nurses in the room. So what the nurses at the time had to do with pen and paper was actually manually measure the things that they did, and it had a corresponding, I think, time associated with the task. I'm looking at Barb, who's long time nurse leader, with an effort to make us more efficient. And that really was the beginning of what I would say was the reductionist approach in healthcare. And so we started to see cutbacks. We started to see staff. There were early retirement packages. There was just a number of things in order to kind of call the workforce and be able to do things in a more efficient manner. Governments across all stripes were trying to figure out how to handle this. So in the beginning, like in the 90s, we had probably 47 hospitals, I think, everybody with their own individual board, an entity unto themselves, but managed through the healthcare system. I believe the next iteration of that was regional health boards. So we were, set in a regional health board environment, but still hospitals had a bit more autonomy. Then we went to district health authorities. So there was 9 district health authorities. That's probably what we remember most recently, 9 district health authorities in the IWK. And then in 2016, we then became one Nova Scotia Health Authority at the time. We now say Nova Scotia Health. And so just this constant iteration, trying to understand about the efficiencies and how we could address the rising costs, the escalating costs. But all the way along, looking at the costs, the slack was taken really out of the system almost in its entirety. And so all of a sudden, around the mid-2000s, early 2000s, but mid-2000s, we started to recognize that we had a gap in our healthcare. And so if you were trained as a registered nurse, you likely graduated by the time you were about 20 or 21, you went into the workforce. So at 60, you had 40 years of nursing behind you, right? Physicians would have been similar. The programs were a bit more short. You were more of a generalist approach. And so in addition to our baby boomers who are aging, in addition to all of the technology and innovation and the ways in which we treated people, like how we treated people 30 years ago and how we treat people today was very different. So the complexity of our population changed. We also had this mass retirement that we were unfolding, and I would say arguably we would see the same thing in education if any of the teachers went to normal college, they called it, and then did some of these things. So we saw the workforce starting to age, and when there was no slack really left in the system at all in the name of efficiency, we then experienced COVID-19. And so if you were worn out or if you were feeling tired, COVID was absolutely the icing on the cake. And we really saw the gaps in the system as a result of that. We saw folks leaving the workforce. We saw burnout, really, the stress of it all. It was just this constant feeling of impending doom. And certainly working in long-term care at that time, there are things, just the constant pressure and urgency that you felt, but you just never knew where the risk was. And so it really was a very difficult time in healthcare. And so we emerged from COVID-19 not entirely unscathed. I think all of us would have our own story about how COVID-19 affected us, not just in our professional life, but in our personal life. And so here we are, emerging from that time. So that would be, kind of an overview of things that kind of brought us to where we are. So as I said, we didn't really also have a lot of systems in place. So I could tell you, I worked in long-term care when I first graduated from nursing school. And then when I came back as an administrator, it's very hard for me to articulate, but something was markedly different. But I didn't have the data. I didn't have the objective data that I needed to be able to articulate that. So it was difficult to demonstrate how things were changing. The complexity of patients. We had some data systems, they didn't really interact. And it was very difficult to say, well, the residents are different. What does that mean? Well, I can't really describe it. They have more diagnosis, but I didn't have any historic data to be able to show that. And so data has proven to be one of the most significant gaps that we have. So in the midst of all of that, we had an election. And so I'm pretty new to politics, registered nurse, a mouthy one at that. Again, there's people in the room that know me, very passionate. There's a couple people raising their hands. Very passionate about healthcare. I absolutely love healthcare. I think it is absolutely one of the most noblest sectors and careers that you can work in, and I don't think it matters in which way you engage in that system. We accompany people from birth to death. We're there on some of the most difficult days of their lives, and we're there on some of the most, euphoric days in their lives, and everything in between. And so I just felt that there was a real erosion in terms of the ability to care, because I still feel that healthcare workers are very caring, they're very dedicated to their patients, but the erosion in the system has led to the ability to care in different ways. And so anyway, I decided that I would put my name on the ballot, never really fully understanding what that would mean. And I continue to learn every day in this role as MLA, and it's an absolute privilege for me to represent Antigonish and certainly to serve as the Minister of Health. So Premier Houston ran on a platform to fix healthcare, and that's no small undertaking. And what that means to me and what that means to you is probably very different. And the questions tonight will kind of lead us to what fixing healthcare means to all of you. There'll be healthcare workers in the room. There'll be folks with aging parents. There may be people who have kids with chronic disease and all things in between. And you're going to be able to kind of lead me around what it means to you to fix healthcare. So we certainly weren't the first government. If I go back in my own recent memory, when the NDP had formed government, there was a lot of work done around emergency room care. They knew that there were things that had to change. And I believe at that time, Dr. John Ross's report came out about emergency rooms, and so really focused on providing emergency care, particularly in rural communities. Certainly the Liberals also ran on a platform to fix healthcare, and that was the government that decided that we needed one Nova Scotia Health Authority to streamline some of our processes and make sure that things are more standardized across the province. And similarly, we were there as well. So Premier Houston was focused. This platform spoke to Nova Scotians, definitely, and really, we came from behind in an election to form a majority government, which, even on election night, I was a bit incredulous because I was so new. First, I won my own seat and I recognized that, but then I couldn't really put my finger on what was happening. And so when we formed a majority government, we were obviously happy, but again, we had come from behind. And I think it really does speak to the importance of that platform of speaking about healthcare to Nova Scotians. So on August 31st, we were sworn in as government, and I was appointed Minister of Health. Minister Barb Adams was appointed as the first Minister of Seniors and Long-Term Care, which makes me very, very proud that as a government, we actually have a minister and a department that is dedicated to the care of elders in our province. It's a really important step, and it just signals the importance of the work and the care that happens in that sector. So that was very exciting for me. And also Minister Brian Comer, who is a registered nurse, was appointed as the minister in charge of the Office of Addictions and Mental Health. And again, first minister solely for that, for addictions and mental health, with a clear focus on that. And while we do have our own portfolios, we do work together, and we actually share staff in the departments in a way so that we do look at an integrated system moving forward. So what did we do? The first thing we did, we held a press conference on, I think, September 1st. And we knew that we needed to try a different approach. So historically, Nova Scotia Health had a board of very, very dedicated individuals that sat on their board, and they acted as stewards in the system. And that system was important. It was historical. And so, information would come to the board. The board would, digest that. They would ask questions. They would assign tasks, committee work, etc. The board, those things would come back. And the system was, in our opinion, moving too slowly. So we did actually, through ministerial order, I think I was a minister for 12 hours and wrote a ministerial order. And we actually thanked the board individually as members, but we dismissed the board. And we appointed a new CEO and a health leadership team. And we did that because we needed a very agile decision-making team. And so the health leadership team consists of Deputy Janine Lagasse, and she's the Deputy Minister of Health and Wellness. Karen Oldfield is the interim CEO of Nova Scotia Health. Dr. Kevin Orrell, who was a former Deputy Minister of Health. He is an orthopedic surgeon, and he was in charge at the time of the Office of Healthcare Professional Recruitment because we knew we had such a gap in workforce. And a lady by the name of Janet Davidson, who's very experienced health leader in our country, in our province, who has nursing background, but has sat on a number of boards. She's been a civil servant in other provinces, served as, I believe, a deputy minister, so very experienced in terms of healthcare. And this group of individuals, although they represent different entities, they come together on a weekly basis and they make decisions for the healthcare system. And that has proven to be a very efficient and effective way to make decisions. It maybe is not the structure that will last forever. We know that we need stewardship. We know that we need community voice. And for right now, this is the model that we have. So it has proven, we've leveraged a number of skill sets. So we have 2 lawyers, a nurse and a physician who are guiding, very different personalities, very different backgrounds, but able to really, put the healthcare system at the forefront. Of course, they report into me, and I, of course, report into the Premier. And so we are very connected as a strategic group moving forward. And we will look as we move on in our mandate, how do we get the strategic voice of community that's well represented so that we can understand the needs of communities across the province. I've learned more distinctly that what happens in Halifax is very different than what happens in rural Nova Scotia and vice versa. And our needs are in some ways common, but in other ways they are not. And so it's really important that we find ways to represent. So that's what we did. We changed the structure of the decision making. The next thing we did is we went on tour. And we did the Speak Up for Healthcare tour. And what we did as a group, the Premier, the health leadership team, and myself, we started touring across the province with a view to speaking directly to healthcare workers. And we started in Neils Harbor. So we started in rural Cape Breton, which was terrific, and we talked to whoever wanted to speak to us in the hospital. We would, we had 2 teams, and we would move around, and so there was somebody compiling the information all the time from healthcare workers, hearing what they had to say, what was working, what wasn't working, what did they need, what were they tired of, really being able to hear those first voices and give some agency. And I have a memory, and I tell it all the time. We were in Truro. I don't know where we had been lots of places. But we had in the evenings, we would come together for like a large meeting. And I remember looking over, and there was a group of healthcare workers, and we were all in circles. And I remember the healthcare workers being leaned in. And I remember the Premier being leaned in and just totally concentrating on one another and what they had to say. And I just thought to myself, what that would have meant to me as a registered nurse, because I had a lot to say, what I wanted to say, right, to have that opportunity, to have the undivided attention of the Premier, and what that meant for me to see the Premier as a healthcare worker, that meant a lot to me. And so I hope people felt that they were held with intention in that space. So we absolutely spent some time compiling that information. And then we went into the legislature 3 weeks after we were elected, which I really did not understand. And so I have a better understanding now, particularly around question period and particularly around the intensity of the media and the intensity around healthcare at that time. I mean, I was pretty green. And but anyway, we got through it. We took it a day at a time. And then in the spring of 2022, we were able to release Action for Health, which is the point, I guess, of what I am here. This is a very cleaned up version. I have a copy, but it's pretty beat up, so they wouldn't let me take it. It's all dog-eared and ripped, and there's coffee on it. And so this is the voice of healthcare workers, is what I would say. And it is our strategic plan. So we'll talk about that a little bit as well. This was supposed to keep me on track and I forget about it all the time. So I'll just keep going. I'm also trying to merge two speeches. So my apologies as we go. So I think what's really important is that often my experience in healthcare was that we did things piecemeal. So we often, we looked at slivers of the system where we felt maybe were too expensive. Maybe there was a certain area that needed a hand. Maybe there was this, maybe there was that. But we really didn't look at the whole system in a way that was intentional and meaningful. So I often tell the story, why, like people say, why is the age-old, why does it take so long? Why do I have to wait so long in the emergency room? And in fact, one of the most significant reasons that you have to wait so long in the emergency room is because there are not enough beds in long-term care. And so if you come back from that, why am I in emerge waiting in the waiting room? Well, one, maybe you don't have adequate primary care, right? Maybe we need to look at what's happening in your community around community-based care and you shouldn't be there. Two, if you are, in an emergency situation and you're admitted, where do I go? I'm on a stretcher and emerge. I can't get admitted to the hospital. Why can't I get admitted to the hospital? Because in the hospital, we have a percentage of individuals, sometimes up to 30 or 35% of seniors, frail elderly and complex, living with complex conditions who are waiting to go into long-term care. And so there has been an absolute underfunding of long-term care for my entire career and perhaps beyond that. And so here we are now trying to create capacity in community. And when we create capacity, that fills up 30% of the beds. Why is my surgery canceled? My surgery is canceled because the bed that's designated for a surgical bed is filled with somebody who has lower acuity needs, but absolutely needs to be in a safe and caring environment, right? And so these are the things that we've been trying to untangle. So the whole system is connected, is what I really want you to know. And when your prescription runs out, when you have sore throat and you think you have strep and you're prone to strep and you have exams and you don't want to miss them, where are you going to go? You have to go to the emergency room. And so you can see very easily how it was backed up. It would get backed up and congested. And, it's not easy to sit and emerge for a long, long time. It's not easy. It's not easy for the paramedics to be there when they can't offload their patients. And so here we were in this situation. And so we had to look at the entire system and move and invest and transform it together. And we're certainly not done yet, but that's some of the work that I can tell you about tonight. So I told you about this, Action for Health. It's a vision and a plan. And I just want to show you, you can see in the picture up there, this is one of the things I'll talk about. This is called C3 and it's our Care Coordination Center. And so the other thing I'll tell you about the beds, because I used to be a nurse manager. And so we had somebody who coordinated beds and then they would have all of the different nurse managers and we had a clipboard. And here was the clipboard. How many beds do you have? Well, let me look. And how many did? Let me look. Oh, well, I need that bed. Well, they can't go to that bed. They need to go to a different bed. Okay, let me look for another bed. So here we would be on a paper-based system. But this beautiful thing, which I don't understand, but there's really smart people that do, can tell us all of the beds. And so, of course, we concentrated it in Halifax first. And we did that because, 50% of our population is there. And if we can crack that nut, then how much easier will it be for us to roll it out across the province? But we will actually, when we roll it out completely, have line of sight in real time. And if you could see into this room, it's a little bit like this, probably a third of it, and everybody's got, things on, like their air traffic controllers is essentially what they're doing. And they are moving people, and there's clinicians, and there's logistics folks, and they are just absolutely working the system all of the time. And so that bed is clean. So, if the bed was clean, I would tell you when I was a nurse on the floor, I was like, oh, that bed's clean. There's somebody in emerge. I'm just going to have a coffee first. I haven't had a coffee yet today, blah, blah, blah. So I might not declare that bed just as quickly as maybe I could have in the old days. And I would hate to admit that, but that sure was what happened. You're right. So now that, that's not there, we still have to staff appropriately. But that is just such an incredible thing. And we actually will be the first province who will roll it out across the entire province. So it is something to be proud of. I'm glad I don't work there. I have deep respect for the people that do. But certainly it's a very important tool for us to be able to, really, it is air traffic control. We are moving individuals throughout this province, repatriating them to their home hospital, getting them to specialty care. And what it allows us to do also is to see where some of the blocks are. So the difference between a surgery and having a surgery canceled could be one nurse. If we don't have the adequate staffing. So when you can see that whole landscape, it allows you to plan in a different and better way. And so then we maybe can find that one nurse to get that surgery, or we can find this, however it would work. And sometimes we can't, but we know why we can't. So we have a vision and a plan, and I'm just going to play you a little video. So that's a little video that we put together when we had a gala, Canadian Medical Association Hall of Fame Awards. And so we were able to put that together because we were really on the Canadian stage. We had a number of pretty fantastic physicians who were receiving awards. And so we were able to kind of put that together to show. So I want to just talk a little bit about what we're doing. What we would say Action for Health is a strategic plan, but it's actually solutions for healthcare is what we would say. And we do have 6 core solutions. And I will go through them a little bit, but not too much, because I think when we get to the question and answer, we'll actually get to where we need to go. What we did this time last year and into March, the health leadership team, Janine Lagasse, myself, and Karen Oldfield, we did 22 community conversations. So we traveled the province again. So the first time we went around, we talked to healthcare workers and we built Action for Health and we started to implement it. And then over a period of about 4 months or so, we traveled the province again and we spoke in communities. But we talked a little bit about what we were doing, but it really was this format that we sat there and we fielded questions and it was very helpful. So I usually have 2 wingmates here, so I'm feeling a little bit lost today, so I'm going to do my very best. But it's very helpful that when we can get into communities and hear what people are worried about. So I'll go through some of the core solutions. They encompass so much, and the work, when I look back to this in the 2022, the work has really deepened and evolved over that period of time. So there's things that we hadn't imagined that are now part of the plan, and there may be things that are matured that we, maybe had, at the surface, but we recognize that they've actually deepened and evolved over time. So the first one is becoming a magnet for healthcare workers. And we really, I'll just move along here. Yeah, what we're doing, I guess. So being a magnet for healthcare workers is really important. We are really up against a global challenge. We are not the only people experiencing healthcare shortages, and I think we see that in the news. So we really had to look at what the barriers were and are to some of that. And I will say one of the biggest, one of the things that we did in terms of enabling, when we look at policy and we look at governance, one of the things that we did was pass in the spring legislature, the Patient Access to Care Act. So legislation then became an enabler, so that we looked at, if you were registered in another province in this country, you actually had to go through a registering process here. So some had a little bit more seamless movement, but most did not. So now we say, if you're a healthcare worker in Alberta, you can be a healthcare worker here. Ontario, Quebec, Newfoundland, good enough for there, good enough for here, because we trust our Canadian systems, and we have a lot of, we're trained the same. Most of our programs, if not all, are accredited, and certainly the professors in the room would know that the best. But you would actually have to register, and in order to facilitate that, actually, when you apply for your license, the first year that you come into our province, because you've paid to be registered in another province, we actually won't ask you to pay again, because that was also a barrier. You had to pay, if you're a physiotherapist, you pay $1,000 in one province, and you have to come and register and pay $1,000 here. So we wanted to take away some of those barriers. So really a common sense approach. And it also put us on to, through our conversations with healthcare professionals, about the red tape. So the other thing that's in that act actually is that you no longer need sick notes. If you're not sick for more than 5 days or for a protracted period of time, you don't need a sick note, because we had so many people that were going to the emergency room, going to their physician or nurse practitioner's office in order to get a note that said, I was sick last Tuesday or whatever it was. So we've actually said, no, we don't need that. And what that did, the work that happened around the sick notes, is a red tape reduction exercise that's undergoing. It's actually a task team. And through that task team, they have identified that by the end of 2024, we can put 400,000 hours back in the system. It's like 1 million appointments. 400,000 hours. It's just mind-boggling that is the amount. And that is through any variety of red tape, insurance forms. If there's any physicians in the room, you just mention an insurance form or nurse practitioners and they just glaze over it. They could be 20 pages long. Yeah, I see Dr. Brennan just like, ugh. So, why are we doing that? What is the most important information? Sick notes, even our own forms in government, we're so work intensive. Like Department of Community Services, I think they had 13 forms that you could use for various different things. So complicated for the clients in DCS, but also very complicated. So working so hard, so 400,000 hours, it's incredible. And not only around productivity, it's not just around getting more appointments, but the work-life balance that restores as a result of that. So that physicians and nurse practitioners and, administrative assistants aren't working into the evenings in order to do that paperwork. That's the other piece. It provides some work-life balance. So then the productivity is gained when you don't have an exhausted healthcare worker that's been up half the night trying to catch up with paperwork. So we are streamlining that. Some are a little bit more complicated, working with insurance companies is an example. So that was a very important piece. So when you wonder about legislation, or you wonder how does it act as an enabler, it really is an enabler. And we depend on folks to kind of see those ways in which we can lean in as government and create policy and enabling legislation. So we had the Patient Access to Care Act. We also worked with our licensing folks. So our college of the Nova Scotia College of Nurses actually worked really, really hard and looked at a variety of nurses, not just within our own jurisdiction of Canada, but internationally. And so how do we make it easier for people? So the College of Nurses actually identified 7 countries where people now can come and essentially be licensed. So there's United States, United Kingdom, Australia, New Zealand, Nigeria, India, and the Philippines. So when we look at the nursing programs and the individuals who come and practice nursing in our province, they're equivalent. They're equivalent. And so we've taken away a lot of the red tape. And as a result of that singular change, there was 18,000 applications filed with the Nova Scotia College of Nurses. So some of them are duplicates. I think we found one individual who applied 15 times. Very focused, very focused. I said, definitely hire them. They're very keen. So, where can we look? So we're looking at that credentialing. So our paramedics, as an example, we would look at jurisdictions like Dubai. Dubai actually has a very equivalent program, and also Australia. When we look at physicians, we've been able to work with the College of Physicians and Surgeons. Dr. Grant has looked at that. We now accept licensure from the United States, which we hadn't before. And physicians coming from the United Kingdom, as an example, no longer need to write an exam. So, as senior, experienced healthcare workers, those exams can become daunting mid-career. So we do still require that the College of Nurses, they do still require the NCLEX exam. I think there's a few probably nursing students in here, so the NCLEX exam is still required. But we are looking at what is the opportunity. And we have a program called Niche, again, when you look at policy, looking at how we bring internationally educated folks here, and how do we help them settle in a very intentional way. So sometimes it's easier to settle in bigger communities, but we also need healthcare workers throughout our rural provinces. So we have navigators, and a good example of that is Ukrainian nationals. So when very unexpectedly, there's a number of Ukrainian nationals who needed to be settled. And so actually hiring Ukrainians to help settle and support Ukrainian healthcare workers in our communities. But also, what does that mean when you don't actually have access to records? So there's some records that are hard to find and hard to get. But when you're in a country, or you come from a country where they actually don't have your records anymore, perhaps they were destroyed, like that, there's nobody working in the offices. What is our opportunity then to look at a skills-based competency-based support in order to bring you in? So those are some of the things that we're looking at. And then just recently in this legislature, we have 21 regulated healthcare professionals in this province, and every single one of them had their own act. So there's a Nurses Act, a physician. We've actually brought all 21 regulated professionals under one singular act. So our code of ethics, how we investigate complaints, there's a lot of similarities between those. And then what is specific to the profession will come up in regulations, and we'll work with the colleges. It also gives us an opportunity to really seamlessly add professionals, so physician assistants. We will now have physician assistants in Nova Scotia. We'll be training them at Dalhousie University. And so much easier now to tuck them, instead of having our own College of Physician Assistants, can we tuck them in under the College of Physicians and Surgeons where they fit really well? Who else can we combine? If it so happens, if you have a regulated healthcare professional with under 50 people, it's really hard for you to do all of the things you need to do. So how can we bring you in under this act and support you in terms of regulating healthcare professionals, or if there's synergies, right, with other professionals? So that's some of the work that's happened. We really are looking at growing our workforce. So we do have a number of seats. And I would also say the collective bargaining process has been very positive for us so far in healthcare. So we did what we called interest-based negotiations with physicians and nurses particularly. And so what we did was we sat at the table, the employer and staff and unions, and said, what are the most important things here? So often it would be like, here's our proposal, and we'll take your proposal, and then we'll fight about the money. But we really wanted to look and say, what is of paramount importance to us collectively? And when we did interest-based negotiations, we were able to talk about primary care, as an example, with the physicians, access to primary care, attachment for patients who are on the Need of Family Practice Registry. These things are really important. And then out of those discussions came, how do we incent? How do we support? What do you need? What can we do? Similarly with nurses, workplace violence is a real issue with nurses in our healthcare system right now. We were able to sit at that table, not me, but certainly representatives, sat at that table and talked about what was really important to the union, to the nurses, and to us around workplace safety for nurses. And so from that, what could we fund? What could we do? What was really important? And of course, the money came after, but it really did build trust and understanding, is what I would say. And certainly we recently settled with the paramedics, and we didn't necessarily have a full interest-based negotiation, but it was positive. All of them went to conciliation, really, which is fine. That's part of the collective bargaining process, and we expect that, but it really was amicable and respectful. And so I am really proud of the work that's happened around our collective agreements, and we will continue through the collective bargaining process. So that also is very, very important, and learned a lot from the government side around how that works. And creating team-based healthcare, really it's important. Our newer healthcare providers want to work in a team base. So, and I say, I grew up in Badek. We had two physicians, Dr. Chow and Dr. Genge. They delivered you. They pierced your ears. They admitted you to the hospital. They looked after your, loved ones. They ran the hospital. They ran their office. They delivered babies. But that isn't the model that we now currently exist. We're different, and physicians are different, and I hear a lot, oh, they don't work as hard. And I would say they work differently. I don't think it's a matter of working harder or not harder. It's a different environment, and I've certainly heard our more experienced and mature senior physicians talk about how it really is a different environment than they maybe started their careers in. So, we want to support people. We want team-based care. We want people to be used to the fullness of their scope. And so pharmacists are a good example of that. So for 20 years, pharmacists have been trained a certain way, and now finally they're able to work independently in the pharmacy clinic. So that's opened up access as a result. So we can go now to certain pharmacies and have our throat swab for strep throat. And in the first 4 months of that pilot, there was about 5,000 people who did not have to go see their primary care provider or go to the emergency room to be treated for strep throat. I mean, that's a significant number of people who were diverted from a system that's already feeling taxed. So I think there's a lot of different things. I will tell you too, sometimes we think little Nova Scotia, so I just want you to know, we are leading the world in certain things. So we have a robotics program here in orthopedics. There are 4 Mako robots in Canada. We have 3 of them in Halifax. So now, as a result of that, becoming a magnet for healthcare workers, because we have 3 of them, we actually will become a Canadian training site for those robotics in orthopedic care. So every single person that's trained on that robot will have an opportunity to come to Nova Scotia, work in our ORs, meet our healthcare workers, see our beautiful province, and see that we really are on the cutting edge. Last week, I don't know if you follow the news, but we actually just purchased, we were doing a clinical trial with this new CT machine that actually takes images of a tumor and radiates it at the same time. So before, we would have a guess, like we knew where the tumor was, but because we couldn't pinpoint it, and because our anatomy changes and things like that over time, if we lose weight or gain weight or tumor grows or tumor shrinks, we would have less radiation over a bigger area, which could cause harm to our healthy tissue. But this Ethos machine with hypersight, they call it, actually will look at that tumor, and it will allow us to have, stronger radiation. I'm not sure if that's the right word, but stronger radiation to pinpoint that tumor as a result. And that is first in the world. It is first in the world, and it's here, and they're publishing papers in Halifax about that. So these are the environments that we are creating, which really do become a magnet to healthcare workers. So I don't want anyone to feel that just because we're here, we're kind of tucked out on the coast. We have some amazing clinicians, and we have some amazing, physicists, and we have data analytics, and we have engineers, and we have all of these different folks who work in healthcare. So there's room for everybody and every gift, is what I would say, in our healthcare system. We're cultivating excellence, and I think I talked a little bit about that. I don't want to get too far. Accountability is a really big issue. So our data systems are very dated and antiquated. We are making decisions without real-time data. We are looking at historical data. We don't have real-time data. It's very hard to be accountable in a system where there's no data, or the data is lacking or lagging. And so really working hard on the accountability pieces. So trying to understand, how many appointments are there in the system in the run of a day? How many patients are people seeing? How many patients are on a list? Those types of things, so that we can really do some planning. And so as a result of, as an example, we now know that every month, because of the interventions that we've made around urgent treatment centers, pharmacy clinics, mobile units, drop-in clinics, we actually have 50,000 on average, 50,000 more appointments available to Nova Scotians to access primary care, particularly episodic care, and virtual care Nova Scotia would be part of that. So we can now see the utilization of that, where people are going, what they're going for, and it helps inform services. And we really did not have that line of sight prior to. And then I talked about C3 earlier. I'm probably supposed to be advancing these slides. Sorry. Yeah, I think this is where we are. So there's just a number of things that are underway, being responsive and resilient. So we really heard loud and clear that communities wanted a restoration of local decision making. So there's a lot of benefits to having one Nova Scotia Health Authority. We can standardize practices. You know, I don't know that we would have been able to respond in the same way to COVID if there had been 9 district health authorities and 9 individual teams trying to roll things out, perhaps, but maybe not. But we did hear from individuals, particularly in rural communities, that they really felt a sense of loss about their rural community hospitals and felt that they wanted more agency over their local decision making. They wanted more integration with their healthcare providers like EHS, like local nursing homes, et cetera. So we are working through that, making sure that people have agency. And, you know, we kind of say these are the non-negotiables. This is where we have to get to in terms of the accountability. But how you get there, if it's safe and ethical, just do it. Like, you figure out what works for you on your resources, on your assets, on your community needs. And we really want to continue to do that. We also, in terms of the responsive and resilient approach, we have the first health equity framework in Canada, and I think it's really essential that we talk about that. So even though we have a publicly funded system, health outcomes are not the same for everybody as a result of a variety of different reasons. So we are looking at how do we lean into communities who have not experienced the same health outcomes as others. So we have a health equity framework. We're looking at increasing representation from diverse groups. We work very closely with Dudjik-Gamik. So Dudjik-Gamik is First Nation Health Authority, Health Association. I guess they don't like to be called authority, but working with community, working with Dudjik-Gamik, the health directors and the chiefs, to understand the health disparities in the community, understand how we support the delivery of healthcare services when First Nation community members come to the healthcare system. What is their experience and how do we improve that? So looking at creating navigators, making sure that there are practices embedded in the healthcare system that are available. So you can imagine, trying to smudge in a hospital where people are worried that the fire alarm is going to go off, what that does to detract from that important ceremony. And I have seen that over my career, right? So we make arrangements and then fire alarm goes off and then you have 10 firemen at the door. So really intentionally talking to community about what is important and making sure that we have representation in our healthcare workers. We work with the Health Association of African Canadians. They instrumental in developing the brotherhood and the sisterhood, which is for African Nova Scotians and Black Nova Scotians who want to receive care, particularly right now in Metro, but we are looking at expanding. We've invested in Pride Health. So there are a number of ways in which equity-seeking community members are coming and telling us, and we need to have really clear policies. One, if you are a patient who experiences racism, and how we are going to approach and address that. And number two, if you're a healthcare worker, because there are a number of healthcare workers in our system who experience racism and discrimination from patients. And so really working hard to address those situations and making sure that we are clear and that we are consistent and that we are fair, and making sure that those things are addressed. We also have invested as well in the newcomer clinic in Halifax, making sure that folks who come, particularly refugees who will maybe have a long period of time where they have not had good health care, that we are addressing healthcare needs, not just in Metro, but across the province as well. And certainly making sure that there is an intentional settlement with an eye to health, and also obviously supportive mental health services, depending on the country and the circumstances from which you came to Canada. And then solution 6, I talk about solution 6, it makes me smile because it's the social determinants of health. And so I really firmly believe that it's so important that we have excellent service delivery and people access the care they need when and where they need it. And I absolutely, but I also think we need to look at what are the things that create health. And so I often will tell the cabinet ministers that I serve with, they get sick of me saying, I am the minister of the healthcare system. and each of you are the ministers of health. And if you think of the determinants, it is represented almost entirely by the cabinet ministries. And I try to frame that so that when we think about it, we work across, because health is such an important issue, we are thinking, how does environment affect health? How does obviously addictions and mental health? Where is the role for early childhood education and education in our system? Where do we look at Department of Natural Resources? All of these different places, how do these determinants, how do these ministries roll up so that we have a healthy and prosperous community and province? So those are some of the things that we discuss. I tell them they can all walk a day in my shoes if they want. They think I have the hardest job in government, but I actually think I have the best. So just depends, I guess. So just quickly, I know I'm taking a bit of time. Beds and people, if we could put it down to two things, beds and people, capacity. We are trying to build more facilities, certainly significant investment in long-term care, investment in community-based care, people, trying to grow our own workforce and attracting people to come and live and work and stay here is really essential for us. And there's a variety of ways that we do that. Looking at designated beds for procedures and surgeries, and really looking at, within that, what is the comparison within our healthcare system? So how much does it cost to do a hip replacement in this hospital or that hospital or that hospital? What is the throughput? Where is the success in one place, and how do we scale it? So offload times is a prime example. The Aberdeen Hospital and St. Martha's Regional Hospital have the best offload times in the hospital. So when we see that and we have the data, we then go to those teams and say, what is the success here? Because the occupancy rates might be the same in the hospital, or, there may be a variety of things that are not different, but there's something different about offloads. So whenever we have that data and it informs us about teams that are functioning quite well, how do we take the learning from that group and then scale it to an area that maybe isn't having as much success for a variety of reasons, right? It's usually a process issue. It's not usually a person issue, that's for sure. We also have to look at people. We want to right size our demographic in this province. So we not only look at healthcare workers, but if we are going to have all this construction of beds, how are we going to get the skilled tradespeople that we need? So as an example, again, to the point around policy, the MOST program. So more opportunities for skilled trades. So certain individuals, if you're under the age of 30 in really sought after roles, in skilled trades in particular, you don't pay income tax on the first $50,000, provincial income tax on the first $50,000 in an effort to have you, to have you stay. So looking at different policies that help enable us to attract the folks that we need. We're investing in innovation. The Innovation Hub is amazing, keeps us on the cutting edge of things that are happening. And I think there's been some students from St. FX that have had the chance to tour that facility. So where are we going? I always say the past is not the future. Everyone says, but what's going to happen? And I don't know. I really don't know. And when I say I'm fixing healthcare, that is going to evolve over the course of my career and every single health minister that comes after me. But this is what I think it means right now. We are going to invest in people, and we are going to invest in the infrastructure and the technology that we need in order to access care. The days of having a physician singularly responsible for all of your healthcare needs, I don't think that is the way of the future anymore. I don't think it's sustainable, and I think there are physicians in the room that would say that, but I also think that we are actually in some ways moving a bit away from that biomedical model and looking at how are we active participants in our care. So I'll draw your attention to the app. We just recently launched an app as an example. So right now that's a navigation tool. It will help you identify resources in your community, or, say you're down the valley for whatever, and you have something that needs to be looked at, you can put your location and we can help you find the services that you need and point you. But over time, that app is going to grow, and eventually you will have your healthcare information in the palm of your hand. We saw it in Denmark at age 16. Everybody gets their medical record on their phone, and it's unbelievable. So I would say that the most important person in your healthcare team typically would have said, oh, that's our physician. It's actually you. It's actually you. So when you have an x-ray and maybe you go to a private physio clinic and the physio says, what does your x-ray say? And you say, well, I don't know, it's at the doctor's office, and then you have to sign a consent, and then it has to go to the doctor, and then the doctor's administrative assistant has to download it and photocopy it and fax it and send it back to the physio. You actually can say, oh, I had an x-ray, let's pull it up and see what it says. right? So the streamlining of care. You know, if I have a dietary issue, I want to see a dietitian, right? What can a physiotherapist do? What can a pharmacist do? So I think what you'll see is that physicians and nurse practitioners will be part of the team that cares for us. And we're getting more and more used to the thought of a health home. So we're not as vulnerable. So if there's a practice and my information and my care team sits there, if there are people that transition in and out, whether that be a nurse practitioner or a family practice nurse or who have you, I am not vulnerable to no care if there's somebody that transitions in and out. And for some communities, particularly our rural communities, we may find that in that health home, there may be a family practice nurse, there may be a diabetic education nurse, there may be a pharmacist or a physio that stays, and there may be physicians and nurse practitioners that actually do locums and move in and out. But the vulnerability is gone because you have a health home. And people know you and they see you over time. And so I think that is going to be the way that we access primary care. And I think we're going to be called on to do things, you know, for ourselves, really think about what our health means. How are we connected to our own health? And how are we, you know, navigating the system in a different way? We are always going to help navigate those that are at highest risk, that need support, right? There are going to be some individuals that don't want the app and they don't want all those things. We're absolutely going to support that. But we also have to change as the system changes as well. So we're going to leverage technology, virtual care. People don't, you know, think we can't see everything through virtual care, but I do want you to know if you're on the Need a Family Practice Registry in particular, you have access to virtual care. If you need to see someone in person, a lot of people don't understand that there are 20 primary care clinics across this province where they actually can refer you for in-person appointments, specifically for those folks who are on the Need a Family Practice Registry. And you can be followed for a period of time as required by that clinic until you do have a family practice where you're attached. We are going to be looking at different modalities and certainly virtual care. And on the app, even if you have a family practice, if you're attached to a care provider, you do have 2 virtual care visits per year that are free of charge for you. So that is a new addition with that app. So that's important too. Again, not for everything, but certainly for some things. So, you know, where are we now? There we go. So more faster. That's the Premier's mantra. I hear it. Yeah, I hear it a lot. More faster, more faster. And what I want you to know is that we feel the urgency, that we know that we were elected on a platform of healthcare. We are working very, very hard, and we are moving as quickly as we can, sometimes quicker than we feel we can manage, but it really is essential to us that we create access, that we create attachment, that we leverage, you know, any available opportunity to us, that we look at the systems that have stayed static over a period of time and how do we move them forward to meet the needs of the population that's in front of us today and the things that we want. We're less patient, I think, than we were 30 years ago. I certainly am. I can say that, you know, in terms of the things that I want and how I want them. And how we consume information has changed as well. So we really are trying to pull the system forward and, you know, really acknowledge the healthcare workers who have been on this journey along the way. It's been tough, absolutely been tough, but I do hope that healthcare workers, and I hope you feel hopeful that, you know, things are changing. And I always end by saying the Premier's given his word, and it means that's a big deal for the Premier. And so he's given his word that he's going to give healthcare everything he's got. And I give you mine as well, that I will do the same. And I want to assure you that the team is working very, very hard. And we ask for a bit of grace and patience. We know that it's certainly not perfect yet, but we are trying very, very hard and open to suggestions. We certainly hear a lot from folks about things that could improve the system, and wherever possible, we do implement them. So that's it for me. I hope that was helpful. Yeah. Sorry, it was long. Didn't expect to be that long. I'm just going to tell you, this is my external brain. So when we go into the legislature, we have question period, and we're not allowed to have our phones, and we're not allowed to have the pages bring us in any information. So they prepare a binder for me that I have to study so that I can answer questions. 50, you don't even know if you're getting a question, but you have to be ready. And so I don't always remember everything. So I brought my external brain today. So if there's a question that you stump me on, I'm hoping it's in this binder. So you'll have to forgive me.
Thank you. I was going to say, are we going to try to sit on these stools?
Try, yeah.
Thank you so much, Minister Thompson. It's exciting to hear about everything that's happening. You've shared a really insightful, informative overview of changes that have happened and are underway. So for this part of the lecture, we'll just move into questions. I'll start with a few questions that came up for me as you were talking. And the first one, really, I was struck by how you described working in the system and noticing that there's a change, like really having a sense that there's something different about the residents that whose care you're supporting in long-term care, but not being able to put your finger on it, and how important having access to information, historical data is to being able to kind of make sense of and explain those changes, which you described as, an increasing complexity of the resident population. And I wondered, just having a bit of background in gerontology, we know there's a real shift towards thinking with complexity and frailty and moving away from this kind of acute care model, especially for complex patients, where you might, put there's a broken bone and you're going to put a cast on it. And I wondered, there seems to be kind of a parallel also with the health system, where it seems that the challenges that we have today are increasingly complex. And so I wondered if you had any thoughts about that, about the faster, stronger, better fixing, and then this increasingly complex system where we have things like AI and so much. So any thoughts or reflections?
Yeah, so I do think it's really important that we leverage technology. I really do. And as an example, we've invested in one patient, one record. So I'll just use that as an example. So we all have healthcare records. IWK doesn't talk to Nova Scotia Health and IWK don't talk to EHS. Long-term care typically would not have an electronic medical record. And so we have all this, and then of course we have physicians who have electronic medical records that don't really speak to any of it. And so we have all this fragmented and compartmentalized portions of our health. And then we have the drug information system as another example. So, here we are with all of these different things. And what that means to us as patients is everywhere we go, we tell our story again and again and again. But when we have an integrated system, one, we all have the same information in a clear line of sight. We can see what other healthcare practitioners have done. We can see where referrals have been made. We share the same information. And despite the complexity, perhaps, of somebody who's living with frailty or a number of diagnoses, we are more of a team, even though we're not necessarily under the same roof. One patient, one record provides the roof, is what I would say. And I don't know if I really understood that as clearly until we did the tour, because I remember Meditech. And so Meditech is the electronic medical record that is in Nova Scotia Health, and it's a bit antiquated. And I remember when that was implemented, actually people resigned. Now, it was a number of years ago, and we didn't have the same access, right? And we weren't as digitally aware as we are now. So I thought that would be a significant barrier, but healthcare workers are dying to have that. They want that so much, and so do patients. So I think, even in terms of how we use the data around AI, how are we predictive? Where are the places that we can anticipate, right? So even though we're all unique and different, there are things that we unfold, and AI can help us understand our systems better, which is why a data analyst is now a healthcare worker, right? So I would never have necessarily assumed that in the past. So the more information we have, the better we are able to understand our communities, our hospitals, our services, our individuals. And I think that's really important. And people worry about data, but I just want to assure people, obviously, we are so careful with people's data. And when we look at it, it's aggregate data. We're not going down into seeing what you do or I do, right? It's aggregate data, and how does that inform us? So it is very important. And when we measure the complexity, like the InterRI tool, which is looking at, folks who live in long-term care and helps to quantify and show over time how complex folks are. That informs staffing. That informs how many beds we build. That informs how wide the hallways are. One of the things that I couldn't get over was the difference in the number of individuals that used power chairs, right, in terms of the mobility aid. So here we are, technology has advanced, but our infrastructure has not. So it just provides such a clearer picture. I mean, you have to overlay it with the story, right, of the individual or the service or the community, but it really does allow us to stop guessing and really lean in and anticipate what's next, anticipate where we need to go, and have the data to show that it's a good investment. Yeah, and if we're successful, like, we have to measure. Like, how do you know if you're successful if you never measure anything, right? And you don't have the outcomes to, you know, show. So I think data is, I underestimated data, and I certainly see that it's going to have increasing value, and AI.
Okay, great. Thank you. And I love how you emphasized, you know, it's not just having access to data, and the way you describe it is kind of like that roadmap again is carrying through, but also like having teams, like having an integrative, collaborative approach, and the difference that can make in terms of trusting direction. I also really like that you talked about or brought up power wheelchairs.
Yes.
And you did talk about health equity, and again, exciting to learn that Nova Scotia really is the first in developing a health equity framework in the way that it has, and through legislation. We know that people with disabilities are often not immediately imagined within health equity work. I think the World Health Organization just released a report in late December 2022 saying there has to be a shift in healthcare. Ableism is the elephant in the room within health, because there's it's just so taken for granted that the expertise around disability is with medicine.
Yeah.
And so I wondered, you know, do you see any possible or potential alignment with work to make the province accessible by 2030? Like, how do you see equity for people with disabilities fitting in with the work that you're doing that to kind of solve the issues with the health system, and then part of broader work, I think, to move an accessibility agenda forward?
So certainly at an individual level, we do have opportunities for people to provide feedback, and absolutely, I know that we regularly overlook, right? We regularly overlook people that are different from mainstream. I will say that I do feel that the work that's happening around the remedy, I think that will be very important. So the remedy is people who live with disability, who were historically institutionalized. And so we really now, under a court-ordered approach, have a responsibility to make sure that people live in a way that they want to live, that they have opportunities to live in community, that there are a variety of different options available to folks who live with physical and cognitive intellectual disability. And we do that across the system. So Department of Community Services leading that work, but health is right there in terms of how we are going to support people living in community. And I believe that, one, first voice is absolutely the most essential, giving people choice in terms of where and how they want to live. Secondly, how do people move around a community? How do people access the medical system? What is our transit? It's going to bring a different lens to the ways in which we provide community-based care and hospital-based care. So I do appreciate that there is much to do, and I think we're on a path where that can happen. And so I look forward to that work ongoing. But again, at an individual level, we do hear from individuals and we seek out opinions and first voice so that we understand where we've fallen short, so that we can make improvements.
Excellent, thank you. And then I'll just do one quick question and turn it over to the audience, and you'll have to bear with me. If you have a question, just please put your hand up and I'll try and make my way over to you. My last question is just, what role do you see rural universities playing in these solutions?
So we're really lucky in Nova Scotia. We have 14, we have a number of universities, and certainly we have, I'm really proud of the Institute for Innovation in Health that's coming to St. Evax. And so really looking at a determinant level, looking at you know, the uniqueness of rural Nova Scotia and what is our opportunity to leverage. And certainly there's people in the room that can speak to, you know, the dream for that facility more than me, but to bring researchers and clinicians and community members together to look at assets in a community, I think to me that's an asset-based approach, looking at the assets, looking at how we can scale up. You know, as a rural person, you know, I grew up in Middle River, like we figured stuff out in a different way. You know, I just feel that there is an opportunity for us to leverage. And I think the way we receive care is really different. I'll give you an example. There is a doctor, Dr. Karen Cross, plastic surgeon, who is the innovator in residence. And I think some folks in the room may have had experience with her. So she's from Newfoundland, and she has created a device that will check blood flow in extremities and also look at wound beds. And she did that because her grandfather was in rural Newfoundland, and the very worst thing for him in order to receive care was to actually drive to be able to see the specialist. He had to be in the car for a protracted period of time. He didn't have mobility in the limb that was affected. It was hanging, it was quite swollen, and he was very uncomfortable when he got home. And so out of that necessity, because of the ways in which we travel, or because of the ways in which, you know, we've concentrated services in a different community, this device was born. So it actually measures blood flow, takes images, and it sends them in a virtual way to the specialist to reduce the number of times, not all the time, but reduce the number of time that an individual has to travel. And so I think that is some of the important work that can happen in rural universities. How do we connect researchers? How do we connect people that have skill sets like data analytics, like IT, all of these different things, and how do we bring them together in a patient-focused way in order to deliver care in a unique setting? So I think there's wonderful opportunity, and I look forward to you know, the work that happens here, particularly since it's my home riding and my alma mater. So
excellent, thank you. Okay, so now we'll open it up to the floor. So any questions?
Thank you, Minister. That was a wonderfully insightful presentation. I have kind of a two-part question for you. Clearly, you have a unique positionality as a healthcare worker and also being in the shoes of a policymaker and being able to make change in policy. So I'm wondering, firstly, how has this unique positionality that you have as a healthcare worker really helped you succeed in your role as Minister of Health? And then also kind of being in these shoes now, what kind of do you wish young professionals in the healthcare industry to know? And also maybe what would you have loved to know being a nurse when you were practicing, kind of being in those shoes that you're in now, making change in policy and really, you know, making these decisions that have impacts, you know, wide-reaching across the province.
Okay. Well, I absolutely love healthcare. I think I've said that a couple of times tonight. I just think it is an absolute, I just think it's a noble profession, and I think it's a wonderful opportunity to accompany folks. I think one of the biggest things I have to be careful that even though I have a deep knowledge of the healthcare system, and I've been fortunate, I've actually worked in healthcare since I was about 15. I worked in a long-term care facility in the kitchen when I was 15 as a part-time job, and played volleyball to avoid it. Otherwise, I wouldn't have played volleyball at all, but it actually started me on a pathway to healthcare. So I have to also be careful that it's not also a barrier. So I have to really be mindful. When I did my master's in counseling, we had a professor that talked about your hooks and your triggers. So where do you over-identify, and where do you feel that you don't want to talk about that, or you don't want to engage, right? And so I have to be really mindful of that. And so I do know that I come with information. It shortens, I mean, they must love it when they brief me, right? Because they don't have to explain everything. But I also have to be careful that it's not a blind spot for me. So I have to be mindful of that. And so if I feel really passionately about something, I kind of do a bit of a check-in with some of the folks that I trust around me to make sure that I'm on the right track. And, you know, am I chewing on something that is, you know, my issue and not the issue of the system. So I'm careful about that. It doesn't always work. You can ask the folks that work around me. They're like, yeah. And I think what I know I'm in a very privileged position. I deeply feel, one, I want to create a healthcare system with my colleagues for Nova Scotians, but I do very much feel the weight of fellow healthcare workers. I don't want to let them down, because we're kind of all in this, scrum together over the course of time. So I've learned a lot. I 100% undervalued the care and the commitment and the work of the civil service, 100%. I am so privileged to see the commitment of the people that I work with now. But I have learned a lot over my time, and I hopefully will be employable when I'm done, whenever that is. Hopefully that I'll be able to come back into healthcare system whenever that time is, when the candidate, like when the voters decide, or when it's over. It really is. We were at a book launch earlier for Dr. John Graham Pohl and his book, and we talked about the art and the science of healthcare, and so it is a bit of a lifelong journey for me. So I don't know if that answers you, but I just think, always learning, always being open. I don't think I really knew how much technology would play a role as we moved on. I felt it was always going to be more person to person, but I see now and accept that technology really is an important enabler.
Other questions?
Hi, you mentioned throughout your talk the importance of the general population being having more agency in their own health. But I found personally, and this could be very wrong, that there is not that much awareness of what good health looks like and how to achieve good health. So have you, for example, been working with the Minister of Education on improving curriculum? Because I found it was pretty bare bones coming through school on health. And how have you been working on increasing education for adults in terms of what good health is and how to achieve it?
Yeah, that's a good question. So we absolutely work with, in my mandate letter. And so the mandate letter, which I didn't know really what it was, but it's like it's the map that the Premier provides you. In the mandate letter for myself, for the Minister of Education, and also the Minister of Agriculture, is really looking at how do we work at a determinants level to work together around education around what is wellness. Obviously the Minister of Addiction and Mental Health going upstream, which is what Solution 6 is about. How are we going to impact people's wellness? So we do have to work with families. And so I would say arguably we start actually prenatally. We work with families, we work with moms, we work with families about what wellness is, around how we manage stress, around attachment, how we love and respond and talk to our babies, and how we make them feel included in our family and included in our communities, and how everything stems from that. So literacy rates, like sitting and loving and reading, those types of things, encouraging families. So we start there. And then when you get to school, how do we make sure that we do things? So part of my job before I was in politics, I worked with health promoting schools, which is embedded in public health. And we look at not just nutrition, but also sleep hygiene. And we look at, when you have school systems, should kids eat first or should they play first? And what is the best practice in real world evidence tell us? So how do we shepherd those kids, and how do we empower teenagers to make the right decisions, and all of those things? So we absolutely have to do that work in order to have a healthy and prosperous province. And I think we're on the road to doing that, which is why, I say you guys are all the ministers of health and I'm the minister of the healthcare system. In terms of older folks, adults, I think, I think there's a lot, we live, all of us, under a lot of pressure and urgency. And so I will say there's an app for that. Like some of the information that's in the app will lead you to different programs. So Your Way to Wellness, as an example, there's a program on there where you can sign up for virtual wellness things. There's a whole variety that's offered through Nova Scotia Health, and I don't know that we leverage that. We also look at rehab programs. We look at cardiac rehab programs downstream a little bit once people have illness. How do you optimize your health and wellness? So it is going to be a staged approach, and I think that's really essential. But we do have work to do, and certainly when we were in Denmark, I had the opportunity to travel to Denmark. There's work that happens at age 65. Every single person gets a visit, whether you want it or not. You get it, and they come in, and these individuals set goals with you. What is your goal? How much activity are you getting? How much of this really in an effort to keep you at home? Right? What's your balance like? How isolated are you? Loneliness. Are you lonely? And then how do we refer people out? So there is work that's underway around some of that, but we do have work to do. We've come a long way, but we have more to do. So I'd say.
Awesome. Thank you. So I also would want to extend my thanks, Minister Thompson. I think this was a great talk, and you've left me feeling very optimistic about healthcare in Nova Scotia.
That's good.
That's great. I do want to push, though, on some of this content around the determinants of health. And as you said, I think it's really wonderful that we're talking about other ministries. And the one that you mentioned that I found quite interesting is, of course, early learning and childcare. So we are in rural Nova Scotia experiencing a lot of challenges around access to care. And this is particularly affecting a lot of women who are working in healthcare, especially in Antigonish County and Guysborough County. We're losing a lot of nurses in particular and having difficulty retaining physicians on account of childcare, especially when we're trying to recruit from afar and we're getting people to come to the province who don't have families, who don't have, neighborhood care networks.
Right.
What are we doing to create more spaces specifically for the healthcare sector around childcare and provisions for care?
Yeah, so it is a difficult nut to crack. There's no question about it, and certainly we are under the agreement with the federal government around creating more access to spaces in a more affordable way, and we're on that journey with education. So in our local community, we do have some seats. So the Maritime Muslim Academy actually has 24 seats that are upcoming. There's also a daycare that's starting in Guysborough as well. We're also looking, there's a pilot project that's happening in Cape Breton, and what we do, or I shouldn't say pilot, it's kind of a bad word now. We talk about test and try. So we look at small, ways that we can do interventions and scale them up. So there is a long-term care facility that actually has a predominantly healthcare worker daycare, so different hours, and also recently announced overnight care, particularly for single parents. So trying to look at a variety of different things. There's no question we have a work shortage in terms of early childhood educators. It's definitely an issue, and so there's been a pay adjustment as an example in the last number of years. I also think when we look at, bringing folks in from, internationally educated folks, what are the opportunities? So very often in some, we actually see predominantly women in nursing who come over and actually send money home and care for their family. But what is the opportunity to settle families in community? And so if we settle a family, then what is the opportunity to have early childhood educators, not just in daycares, but in schools? And if you think about that, what is the capacity? So if I have the same language, I have the same lived experience, if there are children who dysregulate as they should, that's the job of a child, to learn to regulate and dysregulate, then we have folks who have first language in the school, who have shared experience, etc. So we're in the early stages of it, but absolutely we know that it's a barrier, particularly in rural communities. And I do know that there is an action plan that is coming out in the near future from education. Yeah.
Okay, and I just have a quick follow-up one too, just on the issue of family. You talked about the paid care worker, and I wondered, do you have any information you could share with us about supports for the unpaid care workers? Yes. So the backbone of the system, the family caregiver, or the neighbor that drives someone to the appointment, is checking in. Yeah. Anything that's part of this new roadmap for families and friend caregivers?
Yes. So we have an incredible network of individuals in our province, in our country, really, of folks who, through situational reasons, become caregivers themselves. And so Minister Adams in particular is looking at, so she's the Minister for Seniors and Long-Term Care, and we've had a number of conversations around how do we support. So as an example, there is some support programs for people who may need some help traveling, as an example, in order to access surgery. We do know that there are people who miss work as a result of having to support, taking someone to an appointment, et cetera. So we are looking, what are the supports? How do we, wrap our arms around? We're really dependent on these, unpaid caregivers. What does respite look like in the province? How do we support individuals? So there is some early work happening. I can't speak to it in depth. It does predominantly sit with Minister Adams around continuing care, around seniors and long-term care, but certainly, and then what are the different respites required, right? So, do we need respite if if someone you love is living with dementia? Their sleep is most likely going to be disrupted. So, if you're up all night and then you have to work all day, how does that impact? So looking, universally, but also at targeted groups of individuals, what are the needs and how do we best support families in order to be able to maintain folks longer at home, which is where most people want to be.
I wanted to talk about the health equity section. I was wondering how this intends to improve access in healthcare for trans people, and with that, how Nova Scotia's healthcare plan intends to make access to gender-affirming care more accessible, as currently it takes almost over a year just to get HRT, and gender-affirming care like reassignments isn't always covered by the government, and we've seen that it's like 70%. Gender-affirming care reduces suicide in trans people by 70%. So, how is this plan or Action for Health intending to incorporate these trans issues?
Yeah, so we recently in this summer, actually I think it was in July, updated our gender affirming care policy, and we did that with members of the trans community. And so there's been an investment in terms of, making sure that there's better access. So there's a few things, making sure that, that we have education embedded in healthcare programs specifically, and then also working with the colleges. So where folks receive gender affirming care, making sure that there's, once you've graduated, that we do have designated programs where people get the right information. And so in terms of receiving gender affirming care, as an example, there's now a billing code that's specific to that if you're a primary care provider. But in order to use that billing code, you actually have to take the education so that we know that we're getting, the providers are educated and have information that they require, and people seeking trans care have people who are trained. There will be, we have to grow into it. If you're a new practitioner, certainly we need to grow into that experience as we move forward. So certainly there's across the lifespan some individuals at IWK. Some surgeries we are able to do here, but there is expertise that sits in Montreal, and particularly for bottom surgery, the majority of individuals are supported to go to Montreal and also to take somebody with them. And I don't know that we'll ever fully have that, that service here, but what we want is to increase access. Through the gender affirming care policy as well, we also have tried to shorten that window. So to your point, we've removed some of the requirements around different referrals and things like that in order to shorten the time frame. So we're early, we're early days. There has been an investment in the budget. We are looking at making sure that there is safe and equitable access, particularly in rural communities as well. So how do we make sure that we have healthcare providers who have the information that they need, and also if somebody's feeling out of their depth, that there's a clear, process, and also looking at investment in Pride Health. So helping, people access gender affirming care through the system. We actually will have navigators as well to expand that. So I would say that we're on a journey. It's certainly not perfect, but we have made some investments. We've made some changes to the policy and working very closely with leaders in the trans community and the Pride community to help us understand how we better serve the needs of individuals. So, we're not there, we're not perfect, but we certainly are on a path that we feel is good, and that it's informed by individuals who have sought or are seeking care.
Great. And we have a question that's coming in from Zoom. So Bob Foster asks, if the patient is now connected to the system rather than the general practitioner, what is the future of the general practitioner?
Oh, well, the family doctor will always be part of the healthcare team. They're an integral part of the team. And so what I hope is that they are a member of the team, and you know, we all have a scope of practice, and sometimes there's overlap for sure, but we want to be in a supportive environment. We were talking earlier about the relationship of reciprocity. So we want to be in a team where we use people to the best and highest use. And there may be individuals that the physician would prefer another skill set. See, perhaps it's a physio, or perhaps it's a pharmacist, or perhaps it's a dietitian. And so I actually think it will enhance the role of all of the members on the team as a result of being in that environment. It's not for everybody. There may be general practitioners, GPs that want to continue to work, you know, on their own, and they're certainly welcome to do that and in that kind of a more traditional practice. But there's also opportunity for them to work in a team. So I think really it is around choice. It's around the type of practice environment that the physician chooses, and we're certainly open to working with folks, whether that be also on a salary basis or if that's in a fee-for-service basis. So, you know, and also just looking at other ways in which we can support physicians as they enter to practice. So one of the things that we've done is have incubator clinics. So if you're a new physician, we would embed you. Right now we're working specifically with Dow Family Medicine, embed you within the practice. You, over the course of a year, take on your full panel, and then we transition you out to a different practice. So really trying to be very supportive and utilize the skill set on the team, and also looking at how we can best utilize practices. So if you had a practice 30 years ago and you're running it exactly the same way today, it probably is not as, you know, efficient as it was in the earlier days. So really being supportive of physicians, and there's also a physician hotline. So if physicians feel that they need support in terms of their practice, that we can work with them in order to keep them in practice longer, although we know that of course they deserve their retirement. Any physician that we can keep just a little bit longer in the system, we're happy to accommodate if we can. I'm looking at a couple in the room. They're all shaking their heads, but yeah.
I have a question about, this is a very ambitious and exciting agenda for change, and change within, you know, a 50-year, 60-year-old system. What kind of resistance are you getting? And I'm thinking about both resistance with, you know, vested healthcare interests, but also, you know, from Treasury Board and Finance.
So I will say, so Treasury Board and Finance and our cabinet and caucus has been very, very supportive. We certainly ran on an election platform to fix healthcare. So right now there is a significant amount of investment in healthcare infrastructure, into people, all of those things. That is not going to last forever, and I know that, and I don't want to indicate or signal that there is going to be cuts in any way, but we do know that there has been what we would probably refer to as deferred maintenance in our system, right? So we have to invest in OPOR, we have to invest in some of these infrastructure projects in order to kind of advance the system, but that's not going to continue. So, you know, Treasury, I have to go in the morning actually to Treasury and Policy Board, and so, you know, you need to go in there and really talk about what it's going to mean to Nova Scotians, right? So we can't spend money for the sake of spending money. So very, very difficult conversations. We have to be prepared. We have to show the value for money. There's no question about it. There is always resistance. There are people who are early adopters and there are people who are late adopters. But I do think the system as a whole was ready for change. I think, and I'll speak for myself, feeling fairly discouraged in healthcare coming on the end of my tenure. And really wanting to be heard and wanting to engage. So we actually have, you know, certainly Speak Up for Healthcare. I wasn't sure how that would go actually, but there's a lot of engagement. There absolutely are some practices, like we can't continue to do things the same way. And it is harder for some people to change, but that's the culture change that you know, anybody that's in a leadership role knows that is where the hard work really is around culture change. So it is difficult. We've had to have some difficult conversations along the way. But, you know, at the end of the day, we want it to be better. So not everybody is happy. That's for sure. And there are people who have decided to leave, or maybe they need a different, different environment. And sometimes that's exactly what the system needs, and it's exactly what the clinician or the healthcare worker or whatever ever needs. So it's a bit of the art and the science that we talked about before. But it is tough, like we're changing things, and I think you can never over communicate when you're in such a period of change, really being present for people. And I remember doing a course a long time ago that says culture follows the leader. Like, it is the truest thing I have ever heard. Culture follows the leader. And so if you're a leader and you want something different than you exhibit yourself, you're not going to get it, right? And so we have to be really present. So I certainly have deep respect for the leadership team at Nova Scotia Health and IWK, very present for people, a lot of communication. I try to be as present as I can. Certainly deputy, anytime we engage, we do to the best of our ability and explain. And, sometimes no is a complete sentence, and it's not always easy, but we try to be as respectful as we can. And I would say that the healthcare system kind of as a whole has responded and is hopeful. And so you feel the pressure of that as well to deliver. And the Premier is very, very connected to healthcare workers. He knows a lot of people from his time in opposition. He spends a lot of time, in community. If he's in a community, he sees an ambulance base, we're in the ambulance base. He walks into hospital, he's everywhere. He is not going to not know what healthcare workers are thinking. It's not going to be narrated to him. So he's very, very engaged and involved as well. Yeah.
Can you tell us where the big problem space is in terms of resistance, or what are some of those challenges? Like, where would you see a significant challenge, I think, in moving that ship forward?
It's I don't know if I can think of, perhaps there's a particular service we're asking to do something a different way, or I can't actually think of huge pushback, to be honest. I think everybody is really feeling ready for change, and we when there's always an impasse, there's always a point where you reach an impasse, and so you kind of go back to that interest-based negotiation. What are we trying to achieve? What's the non-negotiable, and how we get there, as long as it's safe and ethical? Like, can we wiggle that around based on the assets that we have, or the team that we have in front of us? So far, so good. There has been some bumps along the way, but I don't think I could share anything without maybe identifying the team. Yeah.
Thank you very much for your lecture. I found it very informative and exciting about the future of healthcare in Nova Scotia. I just had a quick question. At the start of your lecture, you talked about trying to free up emergency departments and in the hospital, and the amount of beds taken up by the senior citizens, which could be cared in a different way. But my question's more around how, if we're trying to if we're trying to reorient the senior citizens into the long-term care homes and the facilities like that, what kind of supports are there for those facilities? Because as of right now, we're in a state where the population in Nova Scotia is aging really drastically, where the long-term care homes are in much needed support. You have RNs who are having 75 patients to one RN, and they'll have support from LPNs and ECAs and such, but is there any way that we can support that change over from the hospital and to free up the beds in the healthcare facilities to the long-term care facilities?
It's a great question. So there's been a couple of things that we've addressed. So Minister Barb Adams is a physiotherapist who worked in long-term care, so they certainly have a champion. So one of the things that happened fairly quickly in our mandate was that we increased the wages for CCAs. So continuing care assistants are the backbone of long-term care. Certainly they are. And it's so important that we have a number of folks. So actually right now it is free to train as a CCA. And there's a couple of different options. You can actually go to school, in a classroom setting and kind of work through it for a year, or there's actually a different way that you can become a CCA. It's called Earn and Learn. So, you know, if we're attracting folks, sometimes we attract people at a university, but if you're somebody who's, you know, into a career or into a life and you have rent or a mortgage or a car, the practicalities of life can actually be a barrier in order to change careers. So this allows us to give opportunity for folks to earn and learn at the same time. So we've waived tuition. We're also paying for their books and you know, bringing them into long-term care. So when I was working in long-term care, in 2019, I think in the spring of 2019, we had less, I would say we had less than 100 CCAs graduate from Nova Scotia Community College. So our workforce was incredibly depleted, and we were looking as administrators to find alternative ways. When we waived the fees associated with the program, when we increased the wages, we actually, we graduate about 1,000 CCAs a year, which is pretty significant. So we want to support them. I also think as a registered nurse, working in long-term care is probably one of the most autonomous places that you can work. And folks say, oh, you know, I don't want to work in long-term care, but if you're working in a hospital and the majority of our population who are complex and frail are actually seeking care in the hospital, you're already working in geriatrics. And so really in that setting where residents are predominantly stable and predictable and you know, in an environment where experts work. So nobody in the whole world sees seniors age in place, the continuing care assistants and the staff who work in long-term care. They are experts in long-term care. They are experts in seniors. They see all types of folks. They see all types of families, and a continuing care assistant can tell you very, very quickly who is outside the bell curve when something is going wrong. So I think really as a system, we have to acknowledge the contribution. We did increase the hours of care. So it is 4.1 hours of care. 1.1 of those hours is what we would deem regulated staff, so RN or LPN care. And the rest of the care is given through the care that's provided by CCAs. So increasing the level of care, which has been asked for a long period of time. But there is more work to do. We need to support folks in terms of equipment. So how quickly do we transition folks and make sure that equipment goes with them? So that's power chairs, all the different types of things that enable people to live, you know, full lives, making sure that every long-term care facility has access to the same resources like physio, like dietitian, et cetera. So some homes are 25 people, some homes are 125 people. And so how do we make sure that everybody has equitable access to allied healthcare professionals? So it really is, and then we have to build for the future. So that we will be building more long-term care homes, quite significantly actually. And then we also have to look at how we support community. So I do want to assure folks that long-term care is really important to us, to Minister Adams, to government, to the Premier, and we have invested a lot of money. And I will also say, since I'm on my soapbox about long-term care, they absolutely, the folks that work in long-term care are some of the bravest healthcare workers you will ever find. You know, if you put someone you love, or when I go in there, because I'm all for it, I tell my kids, put me in long-term care. That's where I'm going. I'm going to rock the place. I can't wait when the time comes. I don't want to, you know, I'm happy to go because I've seen the care that happens there. So, long-term care staff welcome you, welcome your loved one. They get to know everything about you. They love you. They truly love you, and they include you as part of their family, and they accompany you for the rest of your life. And then they accompany your family after you're gone, right? They accompany you through that time of death. And then they welcome somebody else, and they do it all over again. And so when we look at some of the other places where we receive and access care, it's a bit more, you know, we can be very caring and compassionate, but in an acute care setting, people change over in a different period of time. So I just cannot say enough about the care and attention that people receive in long-term care. And I have seen it. I saw it as a teenager. I saw it when I started my nursing career, and it was a privilege of my lifetime to work at the RK Macdonald and see the care and the fun. Like, people think that RK Macdonald, nothing happens over there. Spend a couple of days over there. That place is hopping, and funny things happen over there. So it really is a vibrant place to work, and registered nurses and LPNs can actually probably have the most autonomous practice in long-term care than any other sector that they would work in. So I think it's a great spot.
Right, and the aging population certainly is a significant influence on health here in Nova Scotia. What is it, 22.2% of our population is over 65 years of age, and we have such a rapidly aging population. I think it increased by 17% just between 2016 and 2021. So I might ask another question, not seeing any hands up. It's clear the importance of having good long-term care, especially because the strains that may be on the system when people are in hospital but don't have, clinical care needs that require hospitalization. But are there any other changes that are happening within health that that you can share with us related to supporting an aging population? So geriatric specialists or changes in curriculum for healthcare workers or doctors?
Mm-hmm. So I think I don't have a clear line of sight on some of the work that's happening, in the department fully, but there are some things. So certainly we are also looking at community-based care. So how do we support people living at home longer? So there's some folks who aren't like me, who maybe don't want to go to long-term care, that want to live in their community longer. So how do we train a variety of people to provide care? We talk about how do we keep an aging population fitter longer. And so, what are our opportunities? And so certainly I think about kinetic students as an example, and what are the opportunities for community-based programs where we keep our strength up, because strength is really the thing. Strength and balance are really the things that are going to help us sustain living at home the longest. So seniors in long-term care will be looking at that, also looking at some of the barriers in home care. It is difficult right now. We do have a gap in our like I said, beds and people are the biggest gaps that we have. And so making sure that it is a place where a variety of individuals can work, looking at senior-friendly communities. Not everything would sit entirely in health. What are the opportunities across other departments to support seniors? And just innovative ways that we can support folks, making sure folks aren't lonely, as an example. So there is a number of conversations. I never really have a line of sight on the announcements, and so I'm not always sure what I'm allowed to tell, but I can say that there is a focus on seniors, certainly from the demographic perspective, but also because it's the first time that they've had their own department and their own minister. So I mean, that in itself shows that every day there's a dedicated group of individuals who are thinking and talking and planning about senior population and how we support them in community and in healthcare. Yeah.
Great, thank you. So any other questions from the audience?
I think there's a question
from the Zoom. Okay, and we'll take this last question and then perhaps share the mic with Dr. Eisner to give the final remarks. So this is a great presentation. We are on a path of forward movement. However, as minister in a system still very chaotic and broken, what keeps you up at night?
Oh, that's a good question. So I actually sleep like a log because I'm so tired. I just tip into bed, but I'm usually I'm up late tonight. It's like 9, I suppose. Yeah. So I think there's a lot of things. It's so big, and to the person that asked the question, I do worry. I worry about healthcare workers. I worry about people feeling burnt out. I worry, about whether or not the services are going to be there when people need them. And so I think, looking at the system and moving it forward, I am at a very privileged time, right? So here we have political will, here we have investment really in generations. We've never had this investment. So I do think things are better, but I do worry about the staffing. I worry about having enough people. I worry about, our rural communities, making sure that people have access to the care they need. But I am also heartened by the work that's happening, the people that I run into in the healthcare system, the innovation, people's dedication to delivering healthcare to Nova Scotia. And I know we don't get it perfect every time, but I will tell you, it is a big portfolio, and I do worry. But I do believe that we're on a good path. I don't think that really answers it, but it depends on the day, I guess, is what keeps me up at night. But I do sleep. I'm pooped at the end of the day, I will say. Yeah, I actually sleep well most of the time, but yeah. It's just the way I am. I cry a lot when I don't sleep, so everybody tucks me in. Go to bed. I get a bit tearful, a little unreasonable when I don't sleep, so. Yeah.
Hello, everyone. My name is Dr. Anna Zuschlag. I am the Program Research Manager at the Brian Mulroney Institute of Government. I just wanted to give a big thanks to Minister Thompson for coming out tonight. I don't know if the weather fully cooperated with us, but I also wanted to thank everyone on Zoom and in the room with me for coming out. We can't do these events without you, and your participation is so greatly appreciated. I will make another plug for Dr. Kickert's Gov 101 sign-in sheet. So if you want your credit, you must come and sign it. But I wanted to just pass on a little token of thanks to Minister Thompson for joining us. And I also wanted to give a little shout out to Dr. Albrecht for coming out of sabbatical for the evening to be our moderator.
Thank you.
So thank you very much for coming. I will plug upcoming events for the Institute. Please keep an eye out for our announcements. We welcome community members joining us as well. Thank you, students, as well. I know this is a busy time for you. Yes. Thank you very much, everyone.